Good afternoon. I'm Dr. Céline Gounder. I'm editor-at-large for public health at KFF Health News. I'm also a CBS News medical contributor. With me this afternoon is Dr. Atul Gawande, who's the Assistant Administrator for Global Health at the U.S. Agency for International Development, where he oversees the Bureau for Global Health, which is committed to advancing equitable delivery of public health approaches around the world. So I think just to level the playing field and have everybody understand what we're talking about here, what is this job, and what exactly do you do, and why did you take it?
Well, I took this role, which is leading global health foreign assistance at the U.S. Agency for International Development, and I got sworn in January of 2022, in large part because it's the best job in medicine and public health that you've never heard of. Our role is we have about 2,500 people in Washington and in a set of about 80 health offices in countries around the world. We touch 110 countries around the world. And we are kind of the operational muscle for non-military purposes at USAID. It ranges from economic development to disaster assistance to health, the second largest part of the agency. And on health, we've set as our kind of core goal reducing premature mortality, which I've defined as reducing the percentage of deaths in any given country that occur before the age of 50. And so when I came in, the number one thing we had to do was address COVID. And if I've had a singular role, it's been to do our part as an agency in supporting the international COVID response, which now is really focused on recovering all of the lost life expectancy from that period. So it's everything from I'm responsible for, in Ukraine, being able to address keeping the health system going, being able to address how we will rebuild if there's a ceasefire in Gaza, and enable health systems to function, to how do we get to the end point on the finish line on polio eradication. There's a wide range of things that we're involved in, and none of it without work with the CDC, Department of Defense, all of the others. It's a cool role, and I'm just learning constantly.
So your mandate at USAID is to reduce disease globally and to protect the U.S. from health threats from abroad. Yes. But much of your work has been focused on managing emergencies. So initially COVID, Ukraine, cholera, Mpox, Marburg. How does rushing from fire to fire get in the way of achieving bigger, longer-term public health goals?
Yeah, we are constantly surging in, you put it nicely, in firefighting. And if we aren't preventing fires and finding ways to contain the fire once they come out, then we're not doing our job. And a critical part of the strategy that we've taken on, not just at USAID, but across the US government, has been that as we're fighting the fires, we should be taking an approach that builds capacity as we go. I've likened it to trying to build the world's immune system. Our body is constantly surveilling for foreign invasion of infectious disease. We have a rapid detection and a rapid response to contain it in your body and fight it off before it spreads so far widely that it causes catastrophic damage. We have the ability to do the same thing now, and I think we are learning how to do that. We started after Ebola in 2014 and 2015 with working with countries in West and Central Africa in particular to build out, do you have the laboratory capability? Do you have the emergency operations center and the frontline workers being trained to recognize that this might be Ebola or this might be a Lassa fever outbreak, and then to be able to test, call in help, and get an emergency response so you contain it. And those investments, which haven't been that huge, but consistently making these investments, you went from, in 2018, in the Democratic Republic of the Congo, an Ebola outbreak that stretched across borders, killed thousands of people, to, by 2020, each subsequent outbreak has been rapidly detected by frontline workers, recognizing that someone coming in with severe fever, dying suddenly, could be Ebola, protecting themselves with PPE, getting testing arranged, calling the alarm, and the country being able to respond, now with very modest levels of help. And you're seeing this around the world. Our immune system, as it responds, it builds a library of approaches and gets stronger. And in the same way, we're getting faster and faster, not just in the US government, but around the world with partners that are building out their health system. So we've identified 50 countries that are kind of spread around the world, so we minimize our blind spots. Places like Tajikistan and Mongolia as the lone places between Russia and China, that if they are not sharing information about disease, we can learn about it and respond to it quickly.
Now, I think you've referred to this as anti-fragility, not just resilience, but anti-fragility. Can you explain how a response to health threats, these complex, overlapping, intertwined threats, what some of us call wicked problems, how does responding to that make us less fragile and stronger rather than depleted and weaker? Because I feel like that's how we feel here in the US, those of us working in healthcare and public health. I think we feel depleted.
Yeah, the critical thing to understand, so resilience is your ability to withstand a disaster. Robustness is your ability to build capacity to protect as you. Robustness and resilience are both ways of withstanding disaster, but not necessarily being stronger. Anti-fragility is the idea that you get stronger as you face a challenge. And the immune system does that because you build up your library of learning in your body, antibodies and responses that are able to stop disease faster and faster. In a similar way, the reason why it's getting better and better is because we get practice more often than everybody understands. I had no idea coming into this job that there's basically an alert every week about an infectious major outbreak. And taking those as opportunities to now practice, we set a goal, it's become a global goal, of what's called 717. Within 7 days of a virus beginning to circulate and infect human beings that has pandemic potential, we should be able to detect that that virus is there. Within 1 day after it's been detected and confirmed, we should be able to mount an emergency response, and within 7 days, the first steps of that response should be able to be executed, like contact tracing and getting a containment response. And we used to be months. If you just take Ebola, it was typically 4 to 6 months before you even knew the disease was there, and then it'd be 4 to 6 months or longer of response, which is why it would spread so far and wide. When COVID happened, part of the disaster was 2 months of circulating human-to-human transmission before China acknowledged that this was a dangerous situation. And by then, it had spread over borders and was out of control. And so our learning has reduced the time of response in Ebola, for example. It became 55 days, and then it became a month. And then the last outbreak, just about 1.5 years ago, the DRC detected it within the first day of the first person being infected. It was contained to the family that was affected, and little to no assistance was needed. Where just 4 years before, it was billions of dollars and 2 years to get it under control. That's the process we see happening over and over and over as many more places around the world, not just now in Africa, but Latin America, United States, and others get better at responding. Will we be perfect? No. There are constant surprises. We know with avian influenza, we don't know where that jump to humans will happen, and we don't know if it will become transmissible. It's been circulating since 1996, but we are aware that there is a huge danger now that this could happen, and it's building out our capability to respond faster and faster and catch it faster and faster. That's the vital part of it.
You mentioned avian flu, which is a problem among our dairy cattle here in the United States, as well as wild birds throughout the world, other animals, mammals throughout the world. How does the rest of the world view how we're managing avian flu?
Well, there's always learning from everywhere that you go, right? Avian flu, the fact that it has moved to cows in the United States has alerted everybody that most of our strategy globally has been focused on tracking birds and looking for where, farm birds, like poultry, need to be culled. If you find it, then you have to kill the herd, or the flock in this case. Now it's recognizing that we have to look across many kinds of mammals, marine mammals and others, and we're now frantically working through the strategies of what's the best surveillance mechanism that needs to go beyond the birds. And there's lots of debate about how to make it happen. But the experience in the U.S. is teaching the world that we now have to surveil a much wider range of the animal population, and be paying attention. That we have a consistent CDC is the lead on an influenza-like illness surveillance network around the world. WHO is the central coordinator of making it happen, and that system for picking up when people have flu-like illnesses around the world and getting them tested rapidly is the kind of backbone of how we will detect if it jumps to humans, and keeping that system strong is essential. Can I just point out, for example,
yes,
that some of what is being proposed by Republicans, including former President Trump, is to do away with WHO, and one of the things that would disappear is exactly that kind of surveillance system if we were to withdraw from that effort. It's essential we maintain those kinds of capabilities.
We in the United States are still reeling from the after effects of COVID in many ways, particularly in healthcare and public health. How is it continuing to impact health systems in other countries?
Yeah, so we went through the first reduction in global life expectancy in 70 years. It's hard to estimate the impact. It's hard to underestimate the impact. The United States itself went from 79-year average life expectancy to 76 years. And that experience happened all across the world. It wasn't just the effect of the COVID infection itself. It was the way that the damage that was done to health systems generally. You saw health workers having to divert from maintaining regular influenza surveillance, maintaining immunization programs for children. All of those programs got set back. Furthermore, supply chains were disrupted, and countries had to take on huge debt in order to get through the crisis. A country like the US is able to weather that, whereas there's a massive debt crisis going on around the world where countries' currencies have devalued, they can't afford to pay their payments on their debt, and so the money is being taken out of health. Health workers around the world have declined in number. You have basic primary care needs that have really been set back, and people aren't getting paychecks and so on. And you have a number of countries where they are facing potential default. So investment in health is crucial to recover fully from the pandemic. We have set a goal in the United States that we want to not only enable the United States, but support the rest of the world to recover to at least where we were before the pandemic. I think there is every sign the US is on track for being able to achieve that. I think there's every sign that child mortality now has reached where we were in 2019. TB deaths had gone up, and we're starting to claw them back. So I am hopeful that there is progress around the world. But the primary care workforce, which is the backbone of being able to respond in crises and deliver the most life-saving care, they have been widely decimated in the world.
So I was an Ebola aid worker in Guinea for a couple months during the West African epidemic. And I came away very worried that much of the investment into strengthening local health systems was going to be temporary and would be pulled back. But it seems, as you have already described, that there is a different story to be told here. How more specifically did the U.S. partner with West and Central African countries to achieve this reduction in time to response that you described?
Yeah, and it's happening well beyond. But there's a set of what we've gotten better at doing in our health security response, our pandemic response, is being able to track that there are certain measures of capability, like whether you have lab capability to sequence an unknown virus within 24 to 48 hours and have a result. To then take the sequence and be able to match it against, share it and widely share it, identify if it's something that is known and treatable. If it's not treatable, to work to develop new treatments and move very quickly to begin to do that. That production time of getting the information, being able to have sequences, tissue, being able to then respond with the basic elements that have always worked in public health, like contact tracing, identifying PPE, and teaching people how to use it and how to protect, getting the messages out to the community. All of that are part of emergency operations that we are now, is a standard expected of every country in the world. We know many countries don't achieve it, and we're now partnered together, committed with the G7 and other of the higher income partners of the world to build that network out. That is crucial for our protection in the world, and that's why we're working with places that not only in West Africa and Central Africa, but in Central Asia, South Asia, Latin America, Caribbean, and so on. And then the other element of being able to respond is understanding your frontline workforce that every day does the childhood immunizations, does the follow-up for high blood pressure, which is now the biggest killer in the world, and other key conditions, is the key workforce that then when there is a infectious outbreak, a climate catastrophe, this is your flexible workforce and capability. And so we've been working to also enable, in now more than a dozen countries, a program we call Primary Impact, which works with countries to design their program for strengthening their primary healthcare system, have the digital tools that connects the community health workers to the clinics, to the hospital system, get people on electronic records, have supply chains that can make sure that they have stocks of what they need, and the training, not only in recognizing the frontline diseases, but then being able to work, if it's an outbreak, but also then being able to address non-communicable diseases and communicable diseases. That we see as the critical step for enabling capacity.
So 2 days ago, French President Emmanuel Macron joined African leaders to kick off a $1 billion project to accelerate the rollout of vaccines in Africa. What is this program? Why and why now?
Yeah, so it's called the African Vaccine Manufacturing Accelerator. And one of the key lessons that occurred during the pandemic was the world, when crisis hits and you need to address your own population and needs around the world, we all become selfish in that moment. We are going to make sure the vaccines serve our populations first before we make sure it serves the rest of the world. Vaccine production is concentrated in just a couple of core spots in the world. India is the biggest producers of vaccines in the world. The US and parts of Europe are the others. And we were the ones who got hit the fastest. And Africa was last in line to be able to get access to vaccines. We now know that they were among some of the hardest hit with some of the highest excess death rates around the world. And not only they think that that is not an acceptable position. And so jointly with the African Union and the Africa CDC and something called the global Gavi, a global vaccine alliance that brings countries together, committed to building and accelerating capacity of vaccine manufacturing in Africa, and committed $1 billion towards these goals. That is critical if COVID were to become a new variant that evades the current vaccines, but also it's crucial for their ability to know that they'll have capacity for, the new malaria vaccines that are out but are in short supply, HPV vaccines, which can virtually stop most of cervical cancer, which is emerging as a big killer in Africa. And so that was a huge moment. The second part of that was it also launched a 5-year effort to close gaps in availability of some of the newest vaccines that we have available. Malaria and HPV are at the top of the list as a chance to save lives, and then to be able to close the gaps there's more than 25 million children called zero-dose children that have never received any vaccines. We have close to 20 vaccines now that are life-saving and play important parts across the life's course. And so this is a 5-year commitment that the U.S. joined and made a lead contribution towards from President Biden to reduce by half the number of unvaccinated children around the world.
We're talking a lot about vaccines, and we've seen the rise of skepticism about vaccines in this country. How are vaccines viewed in the rest of the world, in the countries where you're working?
There's no question in COVID that COVID vaccination debates ended up producing much higher levels of vaccine hesitancy around the world. And that's been no less true in low-income countries in Africa and other parts of the world. But when it comes to childhood vaccines, the big difference is where there are doubts in the U.S. That have seeped from the COVID vaccine skepticism, you don't see that in the same way. The reduction in child mortality has been much more recent, and people remember when smallpox was a killer. Measles is still killing 100,000 children around the world. You don't have debates in those countries about whether measles are a worthwhile vaccination to be offering. And when you have 8 to 9 million children that we expect to be able to, whose lives we expect to be able to save by vaccinating 500 million more children in the next 5 years, their heads of state are the ones showing up to say, we want to be part of this, and we also want to build the manufacturing capability to make it happen.
As part of better health preparedness, you've called for more integration of healthcare and public health. What can we learn from the global context and apply here domestically? In the US, it seems public health is an afterthought. So just to give you some context, in 2022, the nation spent $4.5 trillion on health, but only $208 billion, or less than 5% of our health spending on public health. In the US, can you even integrate the two effectively, so long as public health remains this ugly stepsister when the resources available for each are so vastly different, when the sources of funding are different, and the outcomes of interest are so different?
Well, when I got this job, I realized that I mentioned we have 2,500 people who are technically excellent, working in over 60 countries around the world. And many of these countries, we've had programs going for years. And you realize that it's an experiment in motion, getting to see what happens as you support countries to develop their health systems. And there are several of them that have, in the course of the last 20 years, rapidly grown the success of their health system to the point that with far less money than we have, they are matching our US life expectancy, that they are even exceeding US life expectancy. There are places like Costa Rica and Chile now have higher life expectancy than the US does. And not only that, they're the longest living people in North and South America, largely because of investment in primary health care and how they've done it. Thailand is my favorite example. Thailand, in the year 2000, 35% of their population died before the age of 50. Their vaccination rates weren't great. They didn't manage blood pressure very well. They had outbreaks of TB, and their HIV crisis wasn't well addressed. In 2002, they started a universal health care reform. And unlike many neighbors in the United States, the first thing that they invested in was wanting to achieve universal primary care. Make a primary care clinic available to every 10,000 people with a physician, a pharmacist, a dentist, and a nursing team. And it was no cost, and essential medicines were free as well. And then partnered as well with creating health outreach workers who visit households in the neighborhood at least once every month to assess their needs and make sure if someone's pregnant that they're getting in for their pregnancy care. If someone has high blood pressure, they're able to refill their meds and follow through on those things and treat people across the life course. The result of that over time was that they ended up matching US life expectancy and then exceeding it. It's now 80-year life expectancy. We're at about 10% of our population who dies before the age of 50, and they are now too, on $300 per person per year for health. Their entire health spending is $300 per person per year. We are $12,000 per person per year. We way underinvest in primary health care. It is under 8% of our total health spend, and most indications are it should be significantly higher. And the core of it was this combination. It's not just, and we didn't see it just in Thailand, all of these countries where they are getting American level or better results with a fraction of our income are doing it by making low-cost primary care with an appropriate mix of, a solid mix of enough physicians, nurses, pharmacists, et cetera, but not waiting for people to come in, having community health workers who visit every home at least once every 3 months so that you don't leave people falling through the cracks. During COVID, we could not get to 95% elderly vaccination until we hired 150,000 community health workers from communities to go door to door, knock on the doors and assess, did you get your vaccine, and make an offer of a vaccine if you'd gotten it. That was paid for out of the American Rescue Plan funds, and then we ultimately got to 95% vaccination. By the way, that's Republicans and Democrats. For all of the debate about it, given an offer of a chance, people took it, and making it simple and easily available. But then we didn't continue that community health workforce in most states. We missed the opportunity to see whether we're addressing hypertension. I see Francis Collins in the audience, and he points out we have 4 million people a year with hepatitis B and C, which are both curable with existing treatments. But we lack that community-based workforce to find the people who didn't get their hepatitis B vaccination or didn't have hepatitis C and haven't had access to the cure, pills that will cure that disease. And that is the component that I think is the secret sauce that makes the systems work around the world.
So the US has been much more focused on ensuring against catastrophic healthcare costs. And as my colleagues at KFF have documented, we're doing quite poorly even at that. It's estimated that about 58% of debts in collections in the United States are for medical bills, and medical debt is the #1 driver of bankruptcy in the United States. So what are we getting wrong? We're not even getting that right.
Well, a couple of things. One is our system is not built to do the outreach. The successful thing is prevention and early detection and response, and it's not just for outbreaks. It's being able to catch the person who, for whatever variety of reasons, are festering at home with, often it can be wounds, it can be chest pain, it can be high blood pressure that's untreated, it can be diabetes, and we don't have the pull system to make sure that people are assessed and brought into the system. Now that is changing, and I think it's some of the biggest news that hasn't been widely reported is in November of last year, Medicare and Medicaid now began paying for community health workers to be able to bill for services for non-doctor office visit-based services. And primary health clinics could do the same. They could also provide non-visit-based services and be able to begin to do that kind of outreach on that same basis. There's a third component we don't do yet, and we have to figure out how to do, that these other countries you called empanelment. That is, geographically, that everybody belongs to a default primary health system, and that everybody would have someone who is responsible for making outreach and assessing needs, especially if you are, at every age there is a need, but especially as you approach middle age and beyond, that's where the highest risk is and the need to be able to make that work. So, we, in some ways, it's the challenge of having built a system. In the 1950s, the Blue Cross system was around the fact that hospitals were the most life-saving thing we had to offer. We didn't know how to treat high blood pressure. We didn't have treatments for diabetes and so on. As we've been able to move to disease upstream, early detection of that people are struggling with problems and prevention begins well outside the hospital, and needing to move our capabilities to that portion of the care.
So let's say we could flip a switch and we would have the Costa Rican health system or the Thai health system here in the United States. What would we be giving up?
Well, here's the striking thing. If you're in Costa Rica, yes, the average life expectancy is above 81 years. Many of you in this audience are not the ones who would really benefit, right? The top quartile, you are better off in the United States than in Costa Rica, because many of you know how to access the system, you're less likely to fester with problems, you're less likely to be unable to get your medications and all of those things. The beneficiaries are the people in the middle in Costa Rica and down to the lowest income levels. And so for many people in this room, there isn't a loss that comes with it, because it's the gain of being able to, we are willing to spend our discretionary income on health. Mm-hmm. The fact that we spend 20% of our income on health is a sign of what we're willing to expend on. But structuring that system so we have a default public-based system, it is very hard to build, and I've not seen private sector systems that are able to play that catch mechanism, except for contracting with them to be assigned, communities where you have that default primary care and system that you offer. It can be private delivery, but at the end of the day, it is a public commitment, at least at the community level, that everybody belongs to some primary clinic and outreach capacity that is there.
Last year, the Washington Post surveyed all 100 sitting U.S. senators, and fewer than half agreed that declining American life expectancy is a public health problem. We have no strategy to reverse this decline, and it's not even a presidential campaign issue. It's not a political priority. Why not?
Well, I think that health outcomes have never been that political. We don't vote on it because the sense is that public figures don't have a lot of control over it. That this is nutrition or this is behavior issues, and there is our share of these issues. Mm-hmm. But a thing that I see that from the global experience that I was not seeing before I'd taken this role was how transformative it is when people have that combination of primary health care and health outreach capacity. I think we're only just beginning to learn that lesson and see these examples. I've made a point of trying to be here, for example, to show what we're learning even from low-income countries in the world that's demonstrating how we can get to even higher levels of survival and outcome in the United States. We think of it as how do I get access to the stem cell transplants, or how do I get access to the latest technology? But we so underuse the existing capabilities that save lives. We bring it to people too late. We don't support their ability to be able to consistently stay on that care. There are a number of things that I think are changing that. Access to healthcare through the Affordable Care Act has brought Medicaid services and private insurance. We've seen reforms in Medicare that I think is strengthening primary care in really significant ways. And it's this gradual process that I think is more significant and more important than it's been given, than there's been publicity about or explanation about the importance of what it's achieving.
Well, thank you, Atul, for your insightful comments. I'd like to open it up to the audience to ask your questions. Here in the third row.
Microphone coming your way.
How are we protected as tourists, like going to India, where there's a lot of infectious diseases?
Well, a couple of things. One is I was just in India a few weeks ago, and the two things. You are, when you're traveling the world, you're always going to be exposed to infections and microbes that you aren't exposed to necessarily, and vice versa. People in India actually ask, during COVID, should we come to America? People were afraid to come here. But there's two things about it. Number one, in any country you go on the State Department website, search for travel, and it'll tell you what the recommended vaccines are that you take, or medications. Like you may be going to, India used to be a malaria endemic area and used to have to take malaria pills before you go. Now that's less so, or it's in other parts of the world that's a consideration. So that's probably the number one thing I'd recommend. And then number two, you take India, for example, the difference between healthcare in the cities now and the United States has become extremely narrow, whereas in the rural areas, you have still a long way to go in the basic development of health systems. We have, within the United States, as wide a gap in survival as we have between countries in the world. And the same is true in the other countries. You will find in India survival rates in many communities that go well beyond what our average survival rate is. In the south of India, with strong public health systems, primary care, high levels of education, and some very good high-level tertiary care systems. And you will find in other parts of India some of the lowest survival rates in the world. In COVID, we had the Native American population had just a 65-year average survival. That meant more than half of their population died before the age of 65. And that was a signal of our own, gaps and challenges that we have.
Other questions? Back here?
Hi there. We're this amazing new technological age, and the ability to use an AI doctor in your pocket or wearables and otherables can really, in India, for example, minimize discrepancies. What would be on your wish list for technology to enable public health that could move the needle?
Well, let me give you some examples of the things that we're already doing, actually. I'm deploying in 7 countries now AI-based chest X-ray. These are low-cost, portable digital X-ray systems, can be carried in a backpack, set up in a primary care clinic, and then attached to a laptop, which will provide a chest X-ray interpretation for pneumonias or TB and other conditions like that. Regulatory reviews indicated that they are as good or better than a radiologist reading for pneumonias. And the combination in Nigeria, for example, of that plus a molecular diagnostic test to confirm if it has a TB detection that it actually is accurate, has increased the entire country of Nigeria's detection rates by 40%. They're finding 40% more cases of TB and able to get people under treatment and under care. the next, so there's a wave of things happening in the diagnostic space. I fully believe that primary care clinicians around the world will be able to have specialist care available with AI-based technologies if carefully introduced and you don't rely on it without some way to confirm things. But AI-based ultrasounds for prenatal care, AI-based skin diagnoses with 90% being able to diagnose with photos. All of those in the next few years are going to start rolling out. And then there's a huge paperwork burden we have in the United States, but also it exists around the world. And being able to document, exams and be able to reduce the time required for medical documentation. At the hospital that I used to be part of, Mass General Brigham, we're deploying an AI tool, and we're also doing it in Eswatini through this work. I don't, there's now, it's become a widespread, people have repeated this several times, so it's worth saying. I don't foresee in the near future that AI will replace your doctor. But doctors who don't use AI will be replaced by those who use AI. It is augmentative, and I believe, and I'm seeing how the pairing of a clinician with an AI tool enables specialized capability to come to a primary care level in ways that's faster, cheaper, and gets people quicker care for the problems they have, and that's going to escalate significantly.
Well, just like physicians who did not use EHRs got phased out.
Yeah.
Very similar. Back here.
Hi, if we can return to avian flu for a moment.
Yeah.
Not just on its own, but also as a model for how we respond to new threats post-COVID. So it's 48 states poultry, 12 states cows, including right here. The USDA allocated $824 million to address it, but it seems like the way that it's being addressed is looking for the presence of it, in particular in cows at the moment, rather than in genomic surveillance to see when it jumps and becomes a threat for human-to-human transmission. Does that seem, in general, that the overall notions of disease surveillance seem to be around catching it within a human diagnostic rather than the genomic shifts that are happening slightly ahead of time? Is that a more reasonable approach or a different way to approach it?
Well, number one, it gets beyond my remit because I'm not part of the domestic response in avian influenza. And second, this is a huge area of debate because here is a virus that I'm involved in trying to surveil for internationally. Been circulating since 1996, gone through many phases of significant scares. This is and then still didn't seem to make the leap to humans. This is a dangerous moment where we're seeing it more in more mammals than ever, and then understanding, well, which mammals do we need to be surveilling in next? Right now, my team, we are primarily following birds so that you can stop it where they are the source. It's really unclear if it's going to be enough mammal-to-mammal transfer that it now becomes something where you should be surveilling all the mammals in the world. There was the die-off in sea mammals in Latin America that we've seen so sea lions, baby seals, etc. But they were contained, and now if I were surveilling baby seals, we would blow all of a very limited budget on that. And so it is an ongoing source of a lot of debate. And while there are really good arguments for any one of them, I have a few $100 million budget, which is a lot of money for this, but deploying it all the way around the world for every kind of pandemic preparedness and response, it's still unclear. I'd say the most critical thing is the influenza-like illness network that CDC and WHO and others drive, because when we start seeing a spike in human cases, we absolutely want to catch it at that point. But debates are out right now, like should we be focusing on pigs. They haven't been infected, but they are the mixing vessel, as it's called, where human viruses can infect pigs and bird viruses can infect pigs. And the worry is that they'd combine, and that's where this would come from. It's widely debated and not clear reasons, and exactly how much money we should be putting into that versus ongoing known measles outbreaks that, as I mentioned, are killing more than 100,000 children as we speak. Or I'm very focused right now on Mpox, where in the DRC, they now have 10 times as many deaths as they did 4 years ago. It has a over 10% death rate in children under 5, and it's a skin-to-skin transmitting pox virus that now has started to cross borders. And so I'm putting a lot of energy and focus there while being alert to and listening to my CDC friends telling me whether we have to shift focus or not.
Well, I want to thank you, Atul, for a great conversation. This has been a real treat.
Thank you, Céline.